Well, it's now 2:30 and we will get underway. So welcome to everyone who's joined us this afternoon for our monthly webinar from the COVID-19 Healthcare Coalition. Today we have an expert panel that will be discussing a really important topic, social inequities and behavioral health challenges in the COVID-19 pandemic. This is a topic that we've touched on in a few different forums in the past, and today we have the good fortune to have a group of distinguished experts. Before that, I'm going to ask Dr. Brian Anderson from MITRE to say a few words of welcome from the coalition.
Great, and thanks, FX. Really appreciate the time that we have here together on this monthly webinar. I think that if there's one thing that I've learned over the past year, it's the power of coalitions coming together, sharing freely and openly, and trying to address challenging problems like the one that we're about to discuss today. So thank you for everyone's time. Thank you especially to our panelists' time and willingness to share with us their expertise and insight into, particularly, I would say, underserved area, which is looking at and trying to grapple with and address social inequities and behavioral health issues associated with the pandemic. So really looking forward to this conversation and the good questions that will come out of it. So FX, back to you.
Thank you very much, Brian. My name is Francis Campion. I'm an internal medicine physician in Boston and one of the leads for digital health at MITRE, and have the pleasure of hosting these monthly seminars. Today we have three panelists, Dr. Larke Huang from SAMHSA, former director of SAMHSA, who will be our first speaker, Rashid Nijah from the CDC, who has a wealth of experience in program development and management, and particularly under the fire of COVID from the CDC. So really looking forward to your comments, Rashid. And Dr. James Schuster, who has tremendous academic experience and has also been responsible for a very large behavioral health network based out of UPMC. So this will be a very rich conversation. Each of our panelists will be giving some opening remarks for 5 or 10 minutes, and then we'll have the balance of time for discussion. And Dr. Anderson and myself, as well as the panelists, will be asking each other the questions. We'd like to invite anyone who's logged in to be able to send questions forward on their chat line. You can send any comments, or if you have other web materials you'd like to share with the other members, other attendees today, feel free to do so. Similarly, the panelists may be putting some items in the chat as far as answers and other resources. We'll be keeping an eye on the chat to try to make sure all those questions get addressed in our Q&A. So without further ado, I'll ask Larke to put up her slides. The rest of us will quiet our cameras and we'll be underway.
Okay, thank you very much, FX. Can you hear me okay?
We can hear you. Terrific.
Well, thanks very much to FX and MITRE and the Healthcare Coalition for inviting me to be a participant on your monthly session. This is a topic near and dear to my career and to what I care about a lot, so I appreciate the opportunity. As FX mentioned, I was formerly with the Substance Abuse and Mental Health Services Administration until December of this past year. And I was the director and created the Office of Behavioral Health Equity at SAMHSA, which was mandated by the Affordable Care Act in 2010 to stand up an office that really focused on health equity issues, behavioral health equity issues in particular. And that was along with 6 other agencies within the Department of Health and Human Services. So I led that office for the last 10 years, and our focus was on looking at inequities and health disparities in terms of mental health and substance use issues. Okay. Okay. So I want to do some quick data snapshots, share with you some mostly from federal surveys, a few from community level studies, to really look at what's happening in terms of COVID racial and ethnic minority underserved communities, and mental health and substance use issues, and really look at the interplay of all of those issues. And really, we're dealing with really multiple pandemics and potential epidemics in the behavioral health sphere. So this really gives you a quick snapshot of cases, hospitalization rates, and death rates among American Indian, Asian, Pacific Islanders, Black, and Hispanic populations. You can see that in each of those categories compared to the white general population, except for some Asian populations. And I have to say the Asians are very diverse. So Pacific Islander, for example, populations look very different than Asian American populations, that they're really carrying a disproportionate share of the burden of COVID cases, hospitalizations, and death rates. This next slide just very dramatically captures the death rate. This is looking at the death rate by race, ethnicity, where you see clearly Black and African Americans dying at 2 times the rate of the white population. And you've heard this, I'm sure, on the news. To look at it graphically, I think it's very startling. And also, if you look at populations that are less focused on, such as the Native Hawaiian Pacific Islander population, again, they are carrying a disproportionate share of the burden of this disease. To look at COVID and the impact on mental health, it's not just an acute issue. It's something that's been going on now for a year. If you look at the data between 2019 and 2020, you see significant increases in the 2 major mental health disorders in this country, anxiety and depression, and 2 times that of serious mental illness. If you look also at suicide attempts, you see an increase in suicide attempts in 2020 at 11.9% of the population having made a serious suicide attempt. And if you look at anxiety symptoms, depression, or suicide ideation, 43% of our population experiences at least one of these mental health symptoms. And so who are some of the vulnerable populations during COVID-19 for mental health issues? The CDC Household Pulse Survey really identified young adults, 18 to 29 years old, as consistently being on the rise in terms of mental health issues of depression and anxiety from April to November 9th. We see high barriers to treatment historically faced by this age group in general. They're one of the highest age levels with a treatment gap, and this is magnified for racial ethnic minority populations. And across all age groups and time periods, Black and Latinx groups report higher rates of symptoms of anxiety and depressive disorder. And those are also the percentage rates for suicidal ideation. In drug use, we have seen an increase in drug use during the COVID pandemic, a dramatic rise in multiple substance use and polysubstance use over the course of the pandemic, and also an increase in fentanyl positivity by age and sex also during COVID-19. We've also seen an increase in overdoses from multiple substances during the COVID pandemic. Our agency had been dealing with the opioid overdoses for the last couple of years, where we started to see a slight tapering off of that in the last year, but in the COVID pandemic, that has also gone up. This slide really gives kind of a summary of what's happening in terms of mental health issues and starting or increasing substance use during the pandemic. You can see, and compared to the white non-Hispanic population, the Hispanic population, again, is significantly disproportionately represented in all of these categories. So that gives you a sense of what's happening in terms of the impact of mental health and impact of the COVID pandemic on mental health and substance use issues, the dramatic and stark disproportionality for populations of color. So I want to share with you this slide, which comes from SAMHSA's annual survey of drug use and mental health issues, to show you before the pandemic, we don't have this yet for this year, that there is historically a significant treatment gap for populations of color. I just pulled out the data for the African Americans because of time, but you'll see that of the people in the African American population that meet criteria for a substance use disorder, that's a bar graph on the far left, 88% receive no treatment. If you look at the population in terms of meeting criteria for any mental illness, you can see that, and this is just before the pandemic, that 69% receive no treatment. If you look at those with serious mental illness, and we look at that as incapacitating at least 2 areas of daily functioning, that 42% receive no treatment whatsoever for a serious mental illness. So I share this particular data slide to say that even before the pandemic, despite high prevalence rates of these behavioral health disorders, mental health and substance use, we already had a significant treatment gap. So that has been exacerbated by COVID, and it's increasing the gap in terms of comparison to the overall US population treatment gap. Explanations for the treatment gap: cost is the most commonly cited reason for not seeking and getting care. And we see higher rates of continued uninsurance and underinsurance among communities of color. Again, that had been starting to, the gap in terms of uninsurance and underinsurance had been starting to close prior to the COVID pandemic. But we anticipate that's gone back to a high rate of uninsurance. The cost is explained 2 times more likely than minimizations of symptoms, and nearly 5 times that of stigma. People often attribute poor access to care or poor accessing care because of stigma. We see that cost in multiple studies seems to be the #1 reason. I wanted to say something very briefly about families and children. We hear less about what's happening with children and adolescents, but we see the increase in worse mental health outcomes, both increases in substance use and elevated suicidal ideation among children and adolescents, and exacerbated for children and adolescents from populations of color. And we know that certainly adolescents in racial ethnic minority groups and those with lower income disproportionately receive mental health services from their schools. So as we see school closures during the pandemic, we're also seeing a disruption of mental health care and substance use treatment for those adolescents who get this treatment via their schools. Okay, so not rather a grim picture, but what can we do to think about how do we address these inequities? Wanted to just go over some policy strategies and some partnership strategies. COVID data disaggregation by race and ethnicity is really essential to know where the need is, where the gaps in care are, and particularly important for behavioral health providers, given the impact on behavioral health, to understand and where the COVID prevalence is in their race by race and ethnicity. Flexibility in treatment policies and payments. We've seen this in terms of increased payer flexibilities. Those kinds of flexibilities are very increasingly important. For example, Black and Latinx populations had the highest rates of opioid overdoses. So these kinds of flexibility in substance use treatment rates and policies provide more protection for people of color. We also look at the importance of navigators of federal stimulus opportunities, whether that's the CARES Act, the New American Rescue Act, that we know that many of these communities have difficulty navigating those potential opportunities. I wanted to just call your attention to this network we've developed at SAMHSA, which is a network of over 1,100 community-based programs serving the behavioral health needs of primarily racial and ethnic populations. And I will put that link in the chat. But we worked with them to help be navigators for community-based organizations serving those populations to take advantage of stimulus opportunities, economic stimulus opportunities. Nearly out of my time, so I'm just going to say that this is a slide on looking at improving access to care through telehealth. and expanded flexible coverage opportunities as well as visit opportunities was tremendous opportunity for addressing mental health and substance use during the pandemic. But keeping in mind the digital divide in terms of many populations, particularly of color, have more limited access to internet opportunities. And we really need to think about digital access as a social determinant of health. Partnerships are critical, particularly working with faith-based leaders and faith-based leaders who are very much using technology now. They are often trusted messengers who have a history of addressing health and mental health promotion and key support and information for communities of color. Community-based organizations, we've been trying to promote the contracting with these CBOs, elevating their capacity to address mental health, behavioral health, and COVID issues. They often have track records in their communities, are trusted entities in their communities, and are multi-service providers that really integrate health, behavioral health, and social services. So we really want people to think about how do you contract with these CBOs. Identifying community-accepted first responders. First responders in certain culturally diverse and underserved communities are not traditional first responders. Not all of them feel comfortable calling law enforcement or EMT when they're having a crisis or when they're having an opioid overdose of sorts for fear of incarceration historically, fear of their children being taken away. So know the community-identified responders. Ways to augment the workforce. I think I'm out of time, so I'm just gonna say you can have these slides, but really looking at what's been done now actually in the administration of vaccines and using medical students and pulling people out of retirement. There's a huge pool of talent of immigrant, refugee, and bilingual health professionals who have been closed out of their professions here. Would be a significant pool to working with these diverse populations. And certainly peer navigators and coaches are often known in their communities and are good for outreach and engagement. Communication channels need to address the cultural diversity of these communities, and constant translation of ever-changing public health guidance is necessary. Finally, addressing structural inequities and racism in society and healthcare is almost a parallel pandemic with the COVID pandemic. We really need to look at a racial equity lens to examine policies and practices. Healthcare systems, sadly, inadvertently at times perpetuate inequities both in practice and policy. We need to look at resource allocation, how our budgets reveal whether they're allocating resources that reflect health equity and equity in the workforce development, and really the importance of connecting racism, racial violence, and discrimination with health outcomes. It's a fundamental contributor to trauma, which often underlies many behavioral health issues, as well as chronic physical health conditions. So that's it for me, and I'll turn it over now to the next speaker.
Thank you, Larke. That was absolutely tremendous. And I think I already have lots of questions for you. And so we'll be coming back to some of your important points there. Thank you. Next up is Dr. Rashid Nijah. And Rashid will tell us a little bit about his background and how he came to be one of our leading voices in this area. Rashid? You can go ahead, turn your camera and just do your mic check.
I'm sorry, I lost where I'm supposed to turn my camera on.
Oh, it's way at the bottom. If you just hover,
okay, I'm good. I'm good now. You can see me? I believe so. So thank you for the opportunity and warm welcome, FX, MITRE, and the Healthcare Coalition. My name is Lieutenant Commander Rashid Njai. I'm the lead for the science team in the Office of Minority Health and Health Equity. Today, I'll be speaking to you about communities of color during COVID-19, and specifically the cultural context that influences health behavior decisioning, public health implications, and community solutions. Before I begin, I wanted to frame this conversation from what I believe to be a critical question. How did we get here? I've asked myself that question numerous times, and I'd like to take a moment to offer a personal account. Over the past year, I experienced the COVID-19 pandemic and response with stress and worry as a Black man, a father of a 3-year-old daughter, the son of a 70-year-old mom who's at risk with comorbidities, and the brother of an unpaid caregiver taking care of my mom. I know my story is not unique and also reflects the experiences of many families of color. I also recognize I had the privilege of teleworking as a full-time employee at the CDC, as a lieutenant commander in the U.S. Public Health Service deployed to the response, a social epidemiologist and community psychologist serving during the summer and fall as team lead for the social behavioral health team within the Community Intervention and Critical Populations Task Force, an eventual senior science advisor for the Chief Health Equity Officer Unit, as well as an intern social worker practicing telemental health here in Atlanta. Here's a brief roadmap of what I'll touch on today. I'll provide a brief background on the impact of COVID-19 in communities of color. I'll share information on adverse childhood experiences, mental health, and social determinants of health. My other goal for speaking with you today is to share new directions in social determinants of health and health equity. And I'll be highlighting priorities of the CDC's COVID-19 Chief Health Equity Officer, or CHEO unit, and the Office of Minority Health and Health Equity, and share for the first time publicly an equity and public health surveillance initiative I'm leading with several partners named Project Refocus, which was funded by the CDC Foundation. I want to frame this conversation from a life course perspective, while taking a moment to highlight the current distressed context that many families, youth, and adults are living in. Notably, I want to emphasize the importance of understanding the link between societal or community conditions and traditional adverse childhood experiences, or ACEs. In the part of the tree above ground, you see the number of adverse childhood experiences, such as forms of abuse, neglect, and some household challenges. But of course, there are many parts of the tree that we don't see, the deep roots. In order to impact the healthy development of a tree and its branches, we need healthy ground for the tree to grow. When we think about ACEs, think about the roots of the tree being the adverse community environments that people live and grow in. Many of these environments are inherited. Environments that contain or perpetuate discrimination, lack of opportunity, and community violence have an impact on whether and how we experience ACEs. It is also important to note that while anyone can experience ACEs, and ACEs cut across all genders, racial and ethnic minority groups, and socioeconomic classes, that does not mean ACEs impact all people equally. Unfortunately, we see substantial disparities in the impact of ACEs in communities of color, and most racial and ethnic minority groups more often experience 4 or more of the traditional ACEs compared to people who identify as white. I'd like to touch briefly on mental health data published by CDC, specifically during the COVID-19 pandemic, and share some work that I was a part of during my time on the response. This work highlights an MMWR on mental health, substance use, and suicidal ideation during the COVID-19 pandemic. The major finding of this research showed symptoms of anxiety disorder, depressive disorder, and suicidal ideation increased considerably in the US from April to June of 2020, compared with the same period in 2019. Additionally, 40% of respondents reported struggling with at least one of the adverse mental or behavioral health conditions presented on the slide. Taking a deeper look at these data, mental health conditions disproportionately affected specific populations, including young adults, Hispanic respondents, Black respondents, essential workers, unpaid adult caregivers, and those receiving treatment for pre-existing psychiatric conditions. Another recently released MMWR by McKnight-Ely et al. Reports a larger percentage of multiracial and non-Hispanic adults of other races and ethnicities reported stress and worry about stigma or discrimination associated with being blamed for spreading COVID-19 than did white or Hispanic adults. Estimates of stress and worry about social determinants of health included possible job loss, ability to obtain needed health care, not having enough food, and housing instability. So what do these data mean? Access to healthcare is in and of itself a social determinant of health. As we advance community mitigation within the COVID-19 response into the vaccine phase, it is also important to consider factors that influence another important determinant of health: access to medical care during the pandemic. It is long established that inadequate health insurance coverage is a major barrier to medical care, and unequal distribution of coverage directly impacts health disparities. Additionally, unreliable transportation also affects healthcare access, as lack of transportation leads patients, especially people at increased risk of severe illness from COVID-19, to miss medical appointments and potentially interrupts their ability to acquire medications. Use of stigmatizing language in medical settings or practices and limited access to culturally appropriate resources are other barriers contributing to reduced access to medical care. The current climate that we find ourselves in as a country requires a new commitment to social justice and innovative ways to promote connectedness. The population health impact of COVID-19 has exposed decades, if not centuries, of inequities that have systematically undermined the physical, social, material, and emotional health of racial and ethnic minority populations and other population groups that are bearing a disproportionate burden of COVID-19. To accelerate COVID-19 disparity reductions, CDC established the Chief Health Equity Officer Unit in the COVID-19 incident management structure with the sole focus of ensuring an all-response approach to identifying actions aimed at addressing health disparities and inequities. I now want to share work that looks at factors that contribute to increased risk from a new lens, one that is community informed and uses the lived experiences of communities of color before and during the COVID-19 response to think about solutions towards real-time surveillance, resilience, recovery, as well as vaccine confidence and uptake. I'm honored to serve as technical monitor for Project Refocus, which stands for Racial Ethnic Framing for Community Informed and Unifying Surveillance. This project is led by Howard University Department of Communication, Culture, and Media Studies, and UCLA's Center for the Study of Racism, Social Justice, and Health. Given the public health observations I depicted earlier, we noted a need to advance a project that looks explicitly at the drivers of harmful social norms, stereotypes, and stigmatizing beliefs, and to identify ways to monitor trends in the population across these complex issues. Funded in fall 2020, the goal of Project Refocus is to explore opportunities for the establishment or expansion of surveillance systems and social listening protocols that effectively monitor in real time the impacts of social stigma on the population. Project Refocus explores the lived experiences of those most directly impacted by COVID-19 related stigma, stories of resiliency and community level observations of public health response and impact, how systems measure COVID-19 outcomes, stigma, and race ethnicity as needed to identify disparities, ways in which any surveillance system may harm the disproportionately affected populations they seek to serve due to their historical role in policing these communities, and recommendations for moving towards the development of an ethical, real-time, equity-oriented COVID-19 stigma monitoring system. I want to share a few quotes from the project that exemplify some of the community voices and stories that emerged relating to stigma for each group first. From the Latino American focus groups and listening sessions, we are all riding the same storm, but we're not on the same boat. It feels that a lot of Latinos are working jobs that are not as privileged, that you can work from home, or that you can take time off if you feel sick, or that even you can pay a visit to the doctor. Here's a quote from the Asian American focus group, which states, "What I really want to see portrayed and emphasized is the Asians that are fully integrated into American culture and society, because that's when really we're equal. When we don't think about being different, I really want to just see the full integration into American culture." Here's a message from the African American focus groups that is brief yet profound. "Yes, we are strong. Yes, we are resilient. But why do we have to keep proving that?" Finally, in mentioning the vaccine from the Latin American focus group, I was honestly thinking of not at the beginning. But the more I've talked to different people, the more I've heard about it, I think I'd feel safer knowing that I had it, and maybe more willing to get out more and feel comfortable in knowing that I'm not going to get it with the vaccine. Next, from the Asian American focus group, like we've all said, there's so much conflict in the whole nation and what we're supposed to do and not to do, and vaccine or not vaccine, that I just try to tune out some of it until I hear somebody say something that is proven, that is across the board 100%. Then I'll perk back up. And last, from the African Americans focus group, just getting access to the vaccine and where the locations are, it is not that easy for people who live in certain neighborhoods. I think we are the most underserved, and even though we are the ones most impacted and the ones who are dying the most from the pandemic, we are not the ones who are getting the access we need. What these quotes exemplify to me are opportunities to address the need for clear and concise data and information about vaccines while speaking to issues around access to vaccines for many communities of color. As I noted, community health and mental health are influenced by several factors, starting from childhood, including social determinants of health. And COVID-19 has exacerbated and unmasked disparities in mental health and social determinants of health. To address these disparities, community-informed and driven models are needed. CDC, through the CHIO, OMHHE, and relationships with community leaders and academic partners like Howard and UCLA, is meeting this need. Ultimately, Project Refocus is an innovative opportunity to elevate community-informed perspectives in helping to inform critical public and community health decision-making by expanding support for trusted messengers and providers such as community health workers, pharmacists, faith leaders, social workers, home and community-based services, and mental health care. Today's conversation for me is an important opportunity to bridge public health, clinical care providers, and community leaders to find paths forward as we define a new normal in these communities of concern beyond a vaccine and other mitigation efforts, leaning towards recovery and continued community resilience. I'd be remiss without acknowledging all the people who helped conduct and support this work, and thank you for your time.
Thank you very much, Rashid. Got lots of great questions for you too. That Project Refocus looks like it's going to be foundational work for the next few years coming. We're now going to call on Dr. James Schuster, Associate Chief Medical Officer and SVP for Medical and Behavioral Sciences at University of Pittsburgh Medical Center. So James.
Thank you. And those were really two wonderful presentations. So I'm going to, and they did a great job of outlining some of the challenges that we have as a society as well within the medical system. And what I'm going to do is give a brief response talking about some of the activities that we've worked on within our health plan, particularly serving our Medicaid members to really try to address those around COVID and specifically around the COVID vaccine, just to give as examples of interventions to try to address some of the significant challenges raised already. So by way of background, again, I'm James Schuster. I'm a psychiatrist by training, and I'm serving as the Associate Chief Medical Officer of the UPMC Insurance Services Division. UPMC is an integrated delivery and finance system. It includes approximately 40 hospitals in Pennsylvania, Maryland, and New York, and has about roughly 4,000 employed physicians. It also includes a set of insurance companies, including behavioral health insurer focused primarily on about 1 million Medicaid members in Pennsylvania, a physical health Medicaid insurer with about 500,000 members, a large Medicare and special needs plan insurance companies, and a significant size commercial plan. My background certainly is I've been now with the insurance division for about 20 years. About 15 years I spent primarily with the behavioral health company, Community Care, and now for about the last 5 years have been involved with behavioral health integration and services, particularly for the Medicaid-related companies. So again, I just wanted to talk a little bit about how we've approached COVID, especially for our Medicaid members, who certainly include significant numbers of minority members, and certainly all have challenges related to their underlying poverty. So what we really tried to do was to try to take a pretty holistic approach and really try to address a comprehensive set of both medical and psychosocial factors for our members. We initially, when the pandemic started, reached out to members who were at high risk of complications from COVID if they got ill. So we created a dashboard that really included both people's medical history based on claims, as well as from some, we also had county sources for some of our members that included things like their housing status, issues around nutrition, and so on, a number of social determinants from human services overseen by the local county. So we were able to include that in our dashboard as well. We worked initially in this outreach both to provide education about COVID, both how to try to avoid it to the degree that they could through distancing, use of PPE, and so on, as well as strategies around coping with the psychosocial issues that affected people, particularly early on in COVID, including losing their job, restrictions around their housing, and childcare issues. We then, over time, reached out to all our members who had positive diagnoses that we were aware of. Certainly many of them we were aware of because they received treatment in the UPMC system. About half of our members received the bulk of their care within the UPMC provider system. About half received care from other providers that if we had knowledge of a positive test or of treatments or other services related to COVID, we reached out to those members both to assess how they were doing, to try to identify their needs, to provide additional education to them, and to make sure that they were getting the medical services that they need. We also worked to enhance the resources available to our care managers. We built a database for the care managers that included community resource referrals really at a zip code level, so that they were able to effectively get information to our members around things like food banks, housing issues, workforce development options, and information both about unemployment resources and employment opportunities. We also worked closely really to get information out and work closely with providers. We had a number of joint provider task forces, both within and without UPMC. As the vaccines have come out over the last few months, Pennsylvania's had challenges, similar to other states, in which the supply of the vaccine to date has not been adequate for the demand, and the vaccine's been targeted at high-risk populations. So we worked closely with provider and other community partners really to try to make sure we were up to date and they were as up to date as we were about vaccine supply in terms of who had supply, where it was available, and how our members could access vaccine. We also have been working really closely with the pharmacy chains, both the retail and regional chains, to really support their efforts and to try to, as best we can, really coordinate a plan for vaccine distribution for our members. We also did some extra training of our member services group. We really frame our member services as really a concierge-like service. Our goal is to really try to resolve whatever issue it is that a member calls in with. So we really provided lots of education and training around that team, around COVID-19 benefit coverage, vaccine distribution, gave them information so they could talk about vaccine efficacy and worries that people might have about vaccine side effects. Reassure people that there's no cost associated with the vaccine, and although it's an ever-changing panoply of information, to provide as accurate information as we could about providers and how to access vaccines. And we really, built on the work that we've been doing all along around things like making sure people had adequate information about their benefits and expanded access to telehealth and other services. We've also really tried to clarify and enhance transportation resources to help people get the vaccine distribution sites. Certainly, there is a transportation benefit that's available to all Medicaid members. So we made sure that folks are aware of that. And we've also been piloting a on-demand transportation service as well, to really try to assess the impact of that, both for Vaccine Connection as well as other health services. We've been really closely tracking the impact of vaccine access in particularly minority communities. There's been quite a bit written about the impact both of vaccine hesitancy in minority communities, as well as social determinants of health barriers like transportation. Our evaluation is that both play a role. We've done some analysis, and clearly the vaccination rate among members who appear to be in relatively similar socioeconomic groups is lower among minority groups, but clearly, so there clearly appears to be a vaccine hesitancy component, but there are also clearly social determinants that play a role as well. So we have been trying to address the social determinant piece, as I talked about, and we're also really trying to address the vaccine hesitancy piece. We actually are in, developing a cross-cultural marketing campaign around engagement with vaccines for minority communities. And we've also developed an internal community ambassador program where we've had our own employees from minority communities who are interested in being representatives in their communities and talking about their experiences with vaccine and sharing information about vaccine in their communities. We've organized that as well, and that activity is also underway. So I know we're getting towards 45 minutes in, so I'm going to stop at this point, but certainly look forward to additional questions and discussion.
Terrific. Thanks, James. And I'll ask each of our panelists to go ahead and turn on their camera and their mic, and we'll go ahead with some questions. We've got a lot to talk about, and never enough time to do so, but I heard the reference to telehealth from, I think, each of our speakers. So I'm hoping we could hear a little insight from your thoughts about what we've learned in this past year, specifically about telehealth, and maybe a little bit of a forecast on where you see it in the next 2 to 3 years, particularly in this population. And I know Larke referenced the concerns about the digital divide. How do we make sure we're providing access as well as the right service? I don't know who wants to start on that.
I'm happy to start, but just to speak a little bit about our data and experience. So there, as everyone knows, there's been a huge burst of telehealth over this past year. With regard to physical health services, there's a significant correlation between the telehealth use and people's degree of anxiety about COVID. So the telehealth use went up dramatically last spring, then declined some, and then bumped up again late fall, early winter as the COVID numbers went up. It's certainly still significantly above where it started pre-COVID, but it's declined significantly from its peak. With regard to behavioral health services, it's the burst of telehealth services was even more dramatic, clearly, and it's continued. So the telehealth use in behavioral has really continued throughout this time. It appears really to be a bit lower in aggregate, although it's still very high in Medicaid than in our commercial and Medicare products, which I think is probably a bit of the result of the digital divide. One of the opportunities that has occurred in the Medicaid program in Pennsylvania is that providers are allowed to deliver telephonic only services, which has definitely been a huge bonus in access for the Medicaid population. And in terms of where this is going to go over the next 2 or 3 years, particularly for underserved communities, I do think that it will be, at least in part, related to this continuation of the opportunity for audio only services because of the digital divide. I know the federal government's also just started one, and I'm sure there are more to come, efforts to bridge the digital divide and to support enhanced digital resources for underserved communities, including rural communities. But that's going to take a while to have impact. So I'm hopeful that the ability to continue the audio only services within the Medicaid program will continue.
So if I can just add to what James was saying, and I think he's right on target with what we are seeing as well, is that there is initial bump up in telehealth services. And we advocated strongly with CMS to reimburse for telephonic services because of the fact that people did not have broadband services or working internet. And we wanted to get reimbursement for telephone services. And we hope that will remain to some degree after the pandemic as well. Anecdotally, it was very interesting. We found that that initially some providers were reluctant, particularly mental health substance use treatment providers, to do telehealth services, weren't sure how they could do it. Once they did it by necessity, they found that it wasn't as challenging as they initially thought, that they in fact could still keep the engagement with their patients. And interestingly, patients embraced it quicker than some of the practitioners did. And that varied by different groups as well. And I think the recent studies that I've seen have been mixed about it. Some have shown that there's been good uptake, but less rigorous uptake by ethnic minority communities. And it's not clear why, if that's privacy issues, if it's being in multi-generational households, crowded households where they can't do it. But there are also studies showing that there has been equal uptake among all populations. So I think the studies are still out on it, but I think with CMS really putting out guidance for payment for telehealth visits and temporarily really enhancing coverage for telephone and video health visits, I think that sort of sprung us into a new world of opportunity, which can go pros and cons. I think for a lot of lower income people who can't get away from their work sites, being able to do telehealth visits was critical. We have a huge drug court portfolio program at SAMHSA where we use treatment as a diversion for incarceration. And for those individuals who had to report to treatment courts or go for regular opioid treatment visits, but could now get take-home packets and also do that telephonically, that really increased their adherence to the treatment protocol. So it really varied on the kinds of services and kinds of populations. I do think it should be thrown into that category of it's really being a social determinant of health, who has access, who doesn't have access. As we go to more digital health, I think will be a critical effort to look at.
And I think I would add, anecdotally, being in Atlanta and Georgia being a state that went full telehealth, and they even allowed interns. So I've had the opportunity over the past year to see all of my clients via Zoom. I think it's been a tremendous lift in terms of the population. I work with underserved populations, underserved youth and their families, primarily providing trauma-informed care. And I think the access issue is definitely a catch-22 in terms of the digital divide and those who can access the technology being able to be on those calls. And so I've been able to witness firsthand kind of the spike that Larke talked about, but then also the decline as this pandemic has extended and people are experiencing Zoom fatigue and people are getting tired because the kids, the parents are all on Zoom, they're all doing online work. So I do think we may need to think about more innovative. So I think as Dr. Schuster also mentioned, being able to just go to straight telephone, I think is also a solution, but I think we are going to come up against a need to be more innovative as that tsunami of mental health issues comes barreling at us over the next couple months.
Yeah, just to add one more statement around that is, I think what we've heard is that the challenge has been around some of the group therapies, how to do that through telehealth or virtually. And certainly in our substance use community, recovery services and supports are often done through support groups, and how to do that through telehealth has been challenging, and people have come up with some very innovative ways to do that and still protect privacy and confidentiality.
Great. Well, it really is about sharing those best practices. So we're hoping that SAMHSA can help us to identify those best practices and then to amplify them, make them the norm. This dovetails really, Rashid, with some of the comments you made about social determinants of health, and I think the call each of you has made about the need to be able to measure what it is we're experiencing or what we're seeing in the community. Can you each talk a little bit about your perspectives on the use of data for describing social determinants of health? How adequate is the data today coming from Medicaid claims, for example, or in the UPMC experience from your combination of public and private data sources, or where do you actually access or get the STOH so that you can identify groups in the most need?
So I'm happy to start. I think the short answer is our data is inadequate at the individual patient/member level. You know, certainly for people that we have direct interaction with, the care management or other staff will collect often, basic information about social determinants, ask folks about housing and nutritional status and so on. But obviously we don't have direct contact with most people. So we do have access to some data from public sources, but again, that's not on everybody. That's just people who might have used the public resources. So if we don't have direct data like that, we have aggregate data, right, from census data, at a zip code level that we can use, so we can get a sense of what the population in specific areas, what challenges they have. But if someone's not engaged in services or engaged with us, we don't typically have, individual level data. So there's definitely more to do.
Yeah, and I think I would echo that I think with a lot of the data sources we're seeing, especially at the federal level, the obvious, the lack of the collection of race and ethnicity data. In particular, I think for me, disheartening is the fact that for syndromic surveillance data, which is one of our key data sources for emergency departments and emergency room visits, we are often blinded because we do not have complete data on race, ethnicity. I think I would also add, I think using uncommon sources, so law enforcement data, unemployment data, I think some of those data sources that may not always lend itself to health, I think can be easily correlated to help infer a lot of what's going on in these communities, especially those environments that I spoke to, that are really the drivers of the social determinants and kind of those upstream factors.
So the data question always surprises me. Amazon has so much data on me. My computer can fill out who I'm sending something to before I type the second letter of the person's name. It amazes me that we don't do a better job of health and social determinants of health data. We do a lot of work with law enforcement and the justice system. They have incredible data. I mean, I think they can spot where I am right now, this very minute, in my dining room. When they talk about doing integrated data with us in terms of health or mental health and law enforcement, they have real-time data. We take so long to process our data. I think the race and ethnicity data, I think it's a double-edged sword. I think people want to know and they don't want to know. And it's always, and Rashid, you can say yes or no, but it's always amazing to me how each of our agency collects race and ethnicity data differently, even though there's an OMB, designation for that. People don't collect all the, granular level within group data that would really be so helpful in terms of looking at needs and treatments and gaps. And I think we can do it if there's sufficient political will. And I think the private sector often wants to partner with us because they say they can do it. They just have to get over our hesitation and in federal government, do we really want to collect this data? I think it's critical to know really what's happening. If we didn't have this data about COVID reluctantly given over by states, we wouldn't know that certain populations were dying 2 times greater rate than others. We wouldn't know where to put resources, and we put resources where people who know they need resources get them, and some people don't. So I think the data piece is really critical, and I think it's a critical accountability issue for healthcare systems as well. And I think healthcare systems are, CMS and our grantees require data collection of race, ethnicity. I think Medicaid requires a requirement. Other healthcare systems don't do it. And then once they say they're going to do it, they don't really know how to do it. Do I look at the person? Do I tell the person to tell me what they are? But I think we really need to get around that if we're really going to really tackle the inequities in our healthcare system.
It's been a challenge in many health systems, and it really does come down to trust. And I think we have an opportunity with the pandemic to gain that trust. People realize how important it is for us to have the right information so that we can help each other. So this could be a big teaching moment for this important aspect of understanding morbidity in our communities. We only have 2 minutes left, and I'm hoping maybe we could ask Rashid to just do a little visioning for us about his project Refocus, and tell us, if we come back in 2 years, what do you think will be, what will we have learned in your hopes and dreams?
So I think for me, it would be, going back to the data issue, I think the importance of community level data and lifting up new ways of thinking about that data. I think it's easy for us to look at data and make sense of it, and it doesn't always make sense to the reality and the lived experience of those who are actually feeling it on the ground. And I think important in that is connecting that data, connecting that empowerment with those service providers who are on the ground. So FQHCs, pharmacists who are on the ground, community health workers, social workers, the people who are boots on the ground, including community clinicians who are there and doing the work, making sure we're empowering not just in one direction, but bi-directional, and so that we keep those lines of communication open, so that, like you said, we can seize this opportunity to really listen to both sides, to listen to the technical and clinical expertise, as well as the lived experience of those members in the community.
Well, thank you. Our hour has passed quickly as we knew it would. I want to thank each of our panelists for the devotion of your careers and for your willingness to share with us today. And hopefully we'll get to do some additional work together in the months and years to come. So thank you so much for all you're doing. I'd like to mention that next month on the third Wednesday, which is the 21st of April, we'll be having our webinar in conjunction with the American Medical Association on the topic of telehealth. And so, as many of you know, we have a joint project through the C19 Coalition called the Telehealth Impact Study. We'll be sharing some of those results with that audience. So you may get some information about that if you're on the distribution list for this webinar series. We hope you can attend. So thanks again for our speakers. And we know in the chat line, several people did ask for some slides, so we'll pass along those email addresses directly to our speakers. And we hope that many of you can take advantage of replaying this in the weeks to come from the website. So thanks again, and stay strong.
Thank you.
Take care.